class. Okay. First of all, the gallbladder, the pancreas, and the liver are all connected. They actually work very closely with one another, and they have that common hepatic bile duct that sort of keeps everything working together, the secretion sort of working together, and then everything gets put in the duodenum. So if you can see in this picture here, that common bile duct connects the liver, which is up top. It connects the gallbladder, and it also connects the pancreas. So there's the pancreatic bile duct, common bile duct, hepatic bile duct, which all essentially end up being pretty much the same thing, that all together at the sphincter of Oddi end up making their way into the duodenum. And so you can see how all of this would be important. And if one piece of the puzzle isn't working correctly, then it makes all of the rest of them not work very well either. Now, the gallbladder is really purposeful for storing the bile that's been made by the liver. So remember, the gallbladder stores the bile, but the liver is actually the one that synthesizes the organ that makes the bile that needs to be used for emulsifying the fat and absorbing the fat that we consume. There are a few common diseases of the gallbladder. I'm going to briefly touch on biliary dyskinesia. We're not going to get into this very much, but you may see it somewhere. Now, this occurs whenever the sphincter of Oddi fails to open properly. We saw back in the slide that was showing how everything is connected. Now, when the sphincter of Oddi doesn't open properly, this can result in an increase in bile and pressure in the gallbladder. And people can end up with abdominal complaints. There's really no nutritional management for this, but it's something that needs to be considered. If somebody is having issues with that sphincter of Oddi, then there can be a backup of bile into the gallbladder and may keep you from absorbing fat the way that you need to. So you may see that, just kind of keep that in mind. The major gallbladder issue that you're going to see is either cholelithiasis or cholecystitis. We'll talk about cholelithiasis first. This is also known as gallstones. It affects many, many Americans. I'm sure you know somebody that's had gallstones. If you don't, consider yourself lucky, because many, many people have had gallstones. Maybe you've even had them yourself. Most gallstones are unpigmented, which means that they're made up of cholesterol, bilirubin, and calcium salts. What happens is bile becomes super saturated with cholesterol, and the precipitation of cholesterol ends up occurring, and that forms these little stones, these little gray stones that you see in this picture here. So that can really be an issue. Now, there are unpigmented and there are also pigmented gallstones. Usually unpigmented gallstones are going to be the ones that are the most common. Unpigmented gallstones are going to be primarily bilirubin and calcium without that cholesterol component there. Now, risk factors for unpigmented gallstones could be 1, sorry ladies, if you're a female; 2, a family history of gallstones; 3, diabetes; 4, age; 5, obesity; 6 could be the number of pregnancies that you've had, or if you are pregnant. Also, body fat distribution can be an issue. Medications such as lipid-lowering drugs and oral contraceptives may play a role. Ethnicity. People that are Pima Indians, Scandinavian, Mexican Americans all have a higher incidence of these gallstones occurring. There can also be gallstones that occur if somebody has very rapid weight loss through a very low-calorie diet or fasting. And just keeping in mind that there are 4 F's that could be contributory factors to cholelithiasis, and that would be being female, being fat, which I don't like using that word, but it starts with an F. So female, fat, fair, so light-skinned, and 40 or older. And risk factors for pigmented gallstones, pigmented gallstones, remember, are those that are made up primarily of bilirubin and calcium salts, are going to be your age. So the older you get, the more likely you are to have it. If you've had sickle cell anemia issues in the past, a biliary tract infection, cirrhosis, and alcoholism. Now, the symptoms for gallbladder issues usually are gallbladder stones, as we call them. It's typically going to be asymptomatic, or there could be abdominal pain if the stone gets lodged in the bile duct and fatty foods are eaten, because those fatty foods then can't be broken down the way that they need to be, and that could definitely cause abdominal pain. Treatment for this usually is going to be either, one, this is very common, the removal of the gallbladder, cholecystectomy. There could be oral meds that are used to dissolve the stones, but this can take a long time. It can take up to 6 months to a year for that to even work. And there might also be a litholytic therapy that can be used as well. It's a laser therapy. But the most common is just the removal of the gallbladder, because luckily, and we can talk about this in class, if somebody can be the point person to remind me about this in class when we meet, your body can function without a gallbladder. It makes a pocket. So if the gallbladder is removed, your body will adapt and still end up having a storage space for that bile, and you may be just fine without it. Maybe at first it might take a little bit of getting used to, and you'll have to eat, as it says here, lower fat food, so it doesn't stimulate that bile being released. Another piece of the nutritional management would be loss of weight if somebody is obese, and increasing the soluble fiber that you're taking in so that it can bind some of that cholesterol that might get absorbed in the gut and take it out the other end for you. Also, the more soluble fiber that you consume, or the more fiber you consume, the less your gallbladder is going to be stimulated to release bile. It slows the absorption of carbohydrates whenever you have higher fiber foods. So if you don't have a gallbladder, then trying to stimulate that situation wouldn't be very good to do. So being careful with how much fat you're consuming, eating more soluble fiber to help slow the digestion and digestion process, and help keep your body from becoming shocked with no place for that bile to be stored, and your body needing bile to break down that fat. Okay. Cholecystitis is another gallbladder issue. This is inflammation of the gallbladder. It's usually due to an obstruction caused by a backup of bile into the gallbladder. The walls become inflamed and infected, and when this infection occurs, it can be very painful. You might feel epigastric pain, so in your abdominal area and your stomach area, you could feel some pain. There might be some nausea and vomiting associated with it. Jaundice could occur when the obstruction happens, and this may lead to an increase, bilirubin in the blood. You might turn yellow, all of that kind of thing. So cholecystitis, when this happens, you really want to treat it similarly to cholelithiasis and avoid any richly fat foods, so rich pastries, chocolate, fried foods, very fatty foods, or gaseous forming foods that might cause discomfort in the abdominal area. You also want to avoid highly condimented foods, as this can cause a distension and an increase in the peristalsis that occurs, and ultimately it can irritate your gallbladder furthermore. So being careful with that. Now, there can be two types of cholecystitis that occur. There can be acute cholecystitis and chronic cholecystitis that occurs. And with acute cholecystitis, initially somebody should stay NPO. What that means is nothing by mouth, and have complete bowel rest to lessen the symptoms of the cholecystitis. Diet should be individualized for every person, but you don't want to be giving a whole lot of fat initially. No more than about 40 to 45 grams of fat. And as you start to resume their diet, just be mindful of that. Not too much fat for them, because again, that if somebody has a sick gallbladder and that gallbladder is trying to put out the bile that's necessary to break down that fat and it can't do it properly, then you may really run into a problem. Also evaluate their weight status. Is there some weight loss that's needed? Do we need to increase the amount of fiber that somebody's taking in? All of that kind of thing play a role in acute cholecystitis. And when we say acute, we mean something that's that happens suddenly, that doesn't last for very long. Not to be confused with chronic. Now, if somebody has chronic cholecystitis, this will usually mean for them a long-term low-fat diet, no more than about 25% of their total calories from fat a day. Their diet too should be individualized. You want to provide fat-soluble vitamins in water-soluble form so that they can absorb them. Fat-soluble vitamins may not be absorbed the way that they need to be if somebody is having issues with that bile being released. So providing fat-soluble vitamins in water-soluble form will help you absorb those better if you're having gallbladder issues. Also, need to check for fat malabsorption and watch those stools. If those stools are fatty stools, and that could mean that you're not absorbing fat the way that you should. And then the last result is to surgically remove the gallbladder, which typically ends up occurring if somebody's had issues over and over and over again with an inflamed gallbladder. And following that surgery, just like you would with the cholelithiasis, you want to give somebody a low-fat diet long-term as they tolerate. And like I said before, over time, the bile duct will form a small pouch that will later serve as a substitute to that gallbladder. Okay, and those are the gallbladder diseases that we're going to focus on in this class. Now let's shift gears and talk about the pancreas. Now with the pancreas, you're primarily concerned with pancreatitis or an inflammation of the pancreas that can either be acute or chronic. Now, the pancreas does have two major functions. The first one is the exocrine function, which produces those enzymes that are necessary for digestion, such as pancreatic lipase, pancreatic amylase, and pancreatic protease for breaking down proteins, fats, and carbohydrates. The endocrine function of the pancreas is that which it produces the hormones that are needed so the body can work properly, like making insulin so that glucose can be absorbed into the cells. So the pancreas does quite a bit, and it's really important for the maintenance of normal nutritional status, particularly since those enzymes are necessary for digestion that it makes. So keeping that in mind, you want to be nice to your pancreas, you want to be nice to your liver, because you need those big time. Okay, with acute pancreatitis, the primary cause is usually going to be due to a biliary tract issue or to alcoholism. Other causes can also be things like drugs, surgical procedures, cancer, perhaps a virus, You really want to be careful in acute pancreatitis with there being autodigestion of the pancreas. What autodigestion is whenever those pancreatic enzymes can't get out of the pancreas, they sort of get stuck in the pancreas and they start to autodigest the pancreas. Instead of going and being used for the digestion of carbohydrates, proteins, and fat, they start to break apart or break down your pancreas. You really just have to be careful with that because you can imagine how painful that would be. Alcohol is going to stimulate an increase in pancreatic enzymes. And so if you have pancreatitis and you're drinking alcohol, that is going to cause edema and make you swell up. And then that will then also cause there to be a block in those enzymes being utilized by the small intestine, so the enzymes end up backing up into the pancreas and cause autodigestion to occur. Now, with acute pancreatitis, it can be very painful. There can be nausea and vomiting involved. Severe fever can happen. Edema. Shock, if it's very severe, people can have bodily shock if it's very severe. And you might see an elevated level of serum lipase and amylase because your body's overproducing those to try to compensate. Now, with somebody that does have acute pancreatitis, you want to keep them MPO initially to avoid pancreatic stimulation. Okay, so nothing by mouth initially for these folks. As the pain starts to reside, you might want to start clear liquids for them and minimal fat. But the thing is if somebody stays MPO or not eating for some time and their amylase and lipase levels are not improving, those enzyme levels, pancreatic enzyme levels are not improving, you may need to put them on total parenteral nutrition or TPN to keep that pancreas from being stimulated at all. Now, that's just going to depend from person to person, and later on in the semester, we'll talk about what total parenteral nutrition is, but essentially, it's a way of providing nutrition that doesn't require you to use the regular method of digestion and absorption, which would be your gut. So it all just goes into your veins. Now, that's sort of a piece that may be necessary with these folks just to allow them gut rest and no pancreatic stimulation. But if you do see that those amylase and lipase levels are starting to improve after a couple of days, then yeah, you might want to go ahead and bypass the TPN and try to give them clear liquids with a minimal amount of fat. When pancreatitis is resolved, though, for them, you want to start progressing the diet as they tolerate. There needs to be easily digested foods that are low in fat. 6 small meals a day are going to be much better tolerated than 3 large fatty meals. And you want to monitor amylase and lipase levels as well as serum glucose levels, because if glucose levels are still super high and the person doesn't have diabetes, and that means that their liver may not be working the way it should. Remember, we said that the pancreas. The pancreas may not be working the way that it should, because remember we said that glucose needs insulin to get into the cells. And so when glucose levels are high, that means that the pancreas is not putting out the insulin it needs to, and that's a function of the pancreas, that endocrine function. So that might still be an indicator that the person is still not well and that their pancreas is still not functioning the way that it should be. Now, there can also be a chronic pancreatitis. This is usually seen with people that have a history of alcoholism. Now, we did say that acute pancreatitis happens with alcoholism too, but you might see just an acute issue with the pancreas if somebody has a binge drinking sort of weekend. So that's what we refer to as alcoholism. But if somebody has, in that case, but if somebody has a history of consistently drinking alcohol all the time, then they may end up with chronic pancreatitis and metabolic stress issues. Now, 2, people that have situations such as cystic fibrosis, which is an inborn error of metabolism, we'll talk about it later in the semester. That can too cause pancreatitis because the body is making a lot of secretions that block certain organs, so it's constantly the pancreas gets constantly blocked, and that could cause chronic pancreatitis. That is different from somebody getting chronic pancreatitis due to alcoholism, although the result is the same. Usually about 90% of the function that somebody has in their pancreas is gone before they get diagnosed with chronic pancreatitis. Clinical symptoms may include excessive weight loss because they're not able to properly absorb the foods they need to because they don't have the enzymes coming out of that pancreas and going into the duodenum and into the small intestine to be used to absorb foods and digest foods. And steatorrhea or fatty stools may be an issue. Steatorrhea, don't forget this term, you may see it again. So steatorrhea could be a huge problem because if you don't have the enzymes necessary to break down the fat, then you're going to get fatty stools. Symptoms of chronic pancreatitis include pain, nausea, vomiting, of course, a decrease in lipase and amylase levels instead of an increase, but a decrease in amylase and lipase levels. Malabsorption, steatorrhea, a glucose intolerance, again, because the pancreas can't make the insulin that's necessary, and weight loss. Now, as far as the clinical nutritional management is concerned, we definitely want to replace those pancreatic enzymes that are being that are not able to be distributed into the gut so that food can be broken down. This is definitely a must if somebody has malabsorption or steatorrhea. And the way that you would replace them is just literally ingest those pancreatic enzymes before you eat your foods. They have amylase and pancreatic amylase, pancreatic lipase that you can take before your meals to help you digest your food properly. Generally, there's going to need to be a low-fat diet that's high in protein. High carbs may be helpful if you don't have that glucose intolerance, because remember, glucose is a direct byproduct of the carbohydrates we consume. So when carbohydrates are broken down, it makes glucose in our body. So watch the levels of glucose. If glucose levels are not too high or are under pretty good control, then you might want to increase the amount of carb to help spare that protein. We're always thinking about sparing protein. MCT oil or medium chain triglyceride oil may be helpful to improve fat absorption and to promote weight gain because it doesn't require, those medium chain fatty acids don't really require all that cleaving the way that the long chain fatty acids do, and break down the way the long chain fatty acids do. And a multivitamin with minerals is essential. Usually you're going to want to give the fat-soluble vitamins, again, in water-soluble form so they can be absorbed. And watch for a B12 deficiency. Usually when there is a lack of protease, then that B12 might be deficient because it can't cleave the way it needs to form that protein. So that is it as far as pancreatitis is concerned, and that concludes the hepatobiliary chapter. Now, there is a case study in your book that we definitely want you to take a look at, and we'll talk about this in class, and we'll go over this in class. But for all intents and purposes, familiarize yourself with this case study of a 45-year-old white woman. She's admitted to the ER with epigastric pain. Upon the collection, not white woman, white male, I apologize, 45-year-old white male. He's admitted to the ER with epigastric pain. Upon the collection of his history, it's noted that he's a smoker. He drinks 6 to 8 beers each evening, and over the last 2 weeks, he has had an upset stomach and when he eats fatty foods, causing him to have nausea and vomiting. The on-call doctor decides to look at his amylase and lipase, and he finds that the amylase is 200 and the lipase is 420. what is going on with this patient. Think about it, and we will talk about it in class when we meet. All right, that concludes our chapter.